Let me now introduce both Evan Salino and Jane Conley. As I mentioned earlier, Evan is a family physician and he works at the Providence Southeast Family Medicine Clinic. He's going to talk about innovative work that the Oregon Health Authority is leading, focused on the Patient-Centered Primary Care Home Program. He's a clinical advisor to that program, and it serves over 3 million patients across Oregon. Dr. Salino works really at the interface between policy and practice. He earned his medical degree and a PhD in medical microbiology and microbial pathogenesis at Washington University School of Medicine in Missouri. And he last participated in a PCPCH event when he spoke at our 2017 conference, which was focused on innovations in primary care. Jane Cooley's worked in healthcare for over 45 years, the first 25 in specialty care and the last 15 in primary care. She's currently the administrator of Springfield Family Physicians, which is a established primary care practice in Springfield, Oregon. It consists of almost 20 clinicians, 10 physicians, and 6 nurse practitioners, and 2 PAs. They also have psychologists and behavioral health therapists, and they have 4 different locations. They've been deeply involved in practice transformation projects and currently have 26,000 patients that they serve. Jane's worked with a number of innovative healthcare leaders over the course of her career. So let me now turn the baton to Evan.
All right, thank you very much, Anne, and thank you to all the people who are tuned in to listen in and hear what we have been doing in Oregon really over the last 5 or 10 years. As Anne pointed out, my role, half my time I spend seeing my own patients and teaching residents, new physicians in family medicine, and then half my time is working with the Patient-Centered Primary Care Home Program, really trying to bridge the gap between policy and practice and inform both worlds about what's going on in the other world. And in this work, I've had a chance over the last 5.5 years to really see a transformation in Oregon primary care occur. And that's really the story that we'll be talking about today. I'm going to describe a little bit about the Patient-Centered Primary Care Home Program that we have in Oregon. It's our medical home program, how it got started, what, sort of some of the function and learning is. I'm really excited to have Jane joining us, to speak really about her experience and her practice's experience as an independent practice in Oregon. And then we will talk as well at the end about some of the primary care investment, collaborative strategies that we've put in place in our state that will guide us over the next 5 or 10 years. Oregon, the Patient-Centered Primary Care Home Program in Oregon really had its roots back about 10 or 15 years ago. Oregon has always had a history over the last 25 years, 30 years of some innovation in our Medicaid system. The Oregon Health Plan, led in a lot of ways, our former governor, Kitzhaber, who was an emergency room physician, led a lot of that work along with legislators. And there's been a desire for bipartisan work to improve health in our state. But about 10 or 15 years ago, we ran into some budget trouble. We had to make budget cuts, and we cut 100,000 people off of our Medicaid program. And we saw results, people who had well-controlled illnesses, hypertension end up in the ER with a stroke, people with seizure disorders end up, having seizures and end up, with brain damage. And overall, it was a very traumatic time for our state. And what happened actually is the state ended up spending more money rather than less in removing coverage for these folks. Out of that really grew an effort to say we need to redefine how we work on healthcare in our state and recognize that there's a finite amount of money that we really should be investing in healthcare, and we need to utilize that a lot better. So Oregon started a process that ended up in a bill passing through our legislature in 2009. It was before the Federal Affordable Care Act healthcare reforms, and it really started a framework for broad healthcare reform in our state. As part of that, the bill laid out a vision, which is almost quoted here in the first bullet, which was to create access to patient-centered, high-quality care and reduce costs by supporting practice transformation, which is a wonderful goal. It's very broad, it's very big, and that's what we wanted at that time. Out of that process, that piece of legislation, a group called the Oregon Health Policy Board was formed, which was a group of folks nominated through the governor's office, multidisciplinary folks to advise the Oregon state government about how to improve health policy in our state. And that group in 2010 set out three, again, very lofty goals for this new patient-centered primary care home program, which was just an idea at this point. One of those goals was to have all of the lives covered by the Oregon Health Authority receive care through a patient-centered primary care home by 5 years from then, 2015. That means everybody in Medicaid, that means all public employees, and that means most teachers in our state. So a fairly large pool of folks. A secondary goal was for 75% of all Oregonians, regardless of their coverage or otherwise, that all Oregonians, 75% of them, would have access to quality care through a patient-centered primary care home by 2015. And the third goal, which was very important, was to align primary care transformation efforts by spreading the model to payers outside of the Oregon Health Authority, so that it wasn't just the state government and their purchasing power as the only force in transformation, but that it was sort of a public-private partnership. So at that point in 2010, the patient-centered primary care home program itself was born. It was established. It had four main goals that are listed here at the bottom of the slide. One was figuring out a way to both define and recognize what a patient-centered primary care home was, and then to also verify what clinics were doing, to refine and evaluate the standards or measures of what was a patient-centered primary care home over time based on evidence and on-the-ground experience and other policy needs in the state. A third task for the patient-centered primary care home program was to provide technical assistance, so help to clinics, so that they could do this work effectively and not all have to reinvent the wheel, but they could work, they could have some help to improve care. And then specific work around communication and provider engagement. And that's really where my role came in as a clinical advisor, as a bridge to the frontline folks, and really collaborating with other folks in the community who also share this work. So these three goals set out by the Health Policy Board in 2010 really guided the work, and the program functions were what the program focused on over time. The first thing that the State of Oregon Health Authority did was to convene what was called a Standards Advisory Committee, a group, a multidisciplinary group of folks who were, from family medicine, pediatrics, internal medicine, nursing, behavioral health, pharmacy, patients, consumers, insurers, a whole group of folks with some knowledge and expertise in primary care and working with primary care to define what this idea of a patient-centered primary care home was, to put some meat on those bones and some structure to that. Now, many of you who are familiar with patient-centered medical homes are aware that, for example, there are multiple different private entities that offer patient-centered medical home recognition. NCQA, National Committee for Quality Assurance, is one of the probably largest in the nation in terms of numbers of clinics. At that time, the NCQA model was in its very first iteration, and folks in Oregon looked at that model, which was made in 2008, and really felt like Oregon's model, they wanted Oregon's model to be a little bit different, or a little more robust in some ways, and just different in other ways. And so the Standards Advisory Committee at that time centered the work of patient-centered primary care homes around these 6 core attributes that are listed here on the slide. Really, there are 4 of them: access to care, accountability, continuity, and coordination and integration, that are the fundamental, building blocks of primary care that folks may recognize from the evidence gathered by Barbara Starfield and her work, demonstrating the value of primary care and the differences that it makes in population health and outcomes. And so those are there as fundamental building blocks of what Oregon has done with patient-centered primary care homes. And then there are 2 other ones: accountability, which is around quality improvement, that sort of work that is newer work as we are able to get more and better data. And then the person and family-centered care piece that is really critical to a lot of the work that we're starting to do now, but it's really new work in a lot of cases in primary care. There are standards and measures that are very specific that lie behind each one of these 6 core attributes. But one of the things I want you to focus on is the language that's written in italics beneath each core attribute. The patient representatives that were part of the original Standards Advisory Committee really felt it was important to focus on what we were trying to do to improve patient care from the patient perspective. And so these were developed with input from a group of folks, patients, and again, clinicians and other folks, but really designed as a promise to patients. So access to care can mean a lot of different things, but really what it means from the patient standpoint is that they want people to be there, their caregivers to be there when they need you. Continuity could be defined a lot of different ways, and it specifically, but really what it means from the patient's perspective is being a partner with them over time and caring for their health. And those fundamental patient-focused definitions really do underlie all of the work of the patient-centered primary care home program. So the Standards Advisory Committee has actually, there's been 3 iterations of them. We put out a new model in 2017, and all of the clinics in the state had to reapply under this new model. There are still 6 core attributes, again, each of them with very specific standards and measures. There are 11 things that every clinic in Oregon must do. They're must-pass measures. And the model was really built by that first Standards Advisory Committee and over time as a model that any clinic in Oregon any primary care clinic in Oregon could achieve at least some level of. There are different levels of recognition depending on the comprehensiveness of the care model in the clinic. Level 1 or tier 1 is the sort of more fundamental or introductory level, and 5-star is the highest level of recognition. And so over time, patient-centered primary care homes have really exploded in Oregon. This is a voluntary program. This is something that clinics choose to do if they want to. There has been policy pieces put in place. There had been 2 years of funding from the federal government through the Health Homes provision of the Affordable Care Act. That was helpful, payments to clinics to do some of this work. That money is no longer continued. There was some state innovation grant money that also funded some of this work. And this work was also built into the redesign of our Medicaid system around coordinated care organizations, which are essentially like accountable care organizations for Medicaid. And really, patient-centered primary care homes were built in as a foundation of this work. What you see here on this map is just a picture of Oregon, and the red dots are all of the patient-centered primary care homes that now exist that are recognized under the 2017 model. So all of these clinics reapplied in 2017. It's about 3/4 of all primary care clinics in Oregon. Again, a little over 3 million people are getting their care through patient-centered primary care homes. There are actually, I think the number is now 40, based on our site visit last Friday, 40 5-star designated clinics, so that those highest level, most robust clinics now in the state. So the growth of the engagement of clinics over time has been astonishing. As part of this work, we have gone out and visited those clinics. So all those dots on the map, those clinics are all receiving visits on an ongoing basis. And we've designed and redesigned the site visit structure, our verification structure in the program, a few times based on clinic feedback, and really aimed at the three models that are, the three goals that are listed there at the bottom of the slide. So this is not a standard sort of audit type of visit where folks from the state come and want to pick apart what you're doing. There is certainly an important verification piece that's important for the integrity of the program. And when clinics say they're doing things, then there's an important role for the program that the program plays to make sure that they're actually doing the things that they say they're doing. However, the site visit structure and goals don't stop there. They also include assessing more comprehensively how the clinic is delivering care, how their teams work, how they're actually transforming, far beyond any specific standards or measures or boxes that they've checked or numbers that they may submit in terms of data, much more about the culture and transformation process in the clinic and assessing that, and then collaborating with the clinic to identify areas for them to improve that they want to improve on, and trying to connect them with colleagues and other folks to help them do this work. The goal of the program is engagement and getting clinics to really stretch and do as much as they want to do and can do, and utilize these site visits as a mechanism to really foster that process of growth. You know, we learned a number of things in doing site visits across the state. There's certainly a significant amount of variability, but there are also a lot of patterns that are clear. You know, I was shocked. I've gone to many of these visits across the state. I visited every size of practice, from one doc practice where his wife is the receptionist, to every health system in the state. There are innovative processes everywhere. I thought going into this that there were probably one or two or three right ways to do things like care coordination or behavioral health integration or to provide preventive care or to do team-based care, but actually there are many ways that clinics find to do this work. And those are based on their population, based on the folks that they have working in their clinic and their workforce, based on some of the resources that they have available to them. We also found that there's really universal need for help and assistance wherever folks are in the process of medical homework or patient-centered primary care homework. Folks always need and want help. They're just at they have a little different perspective if they've been doing this work 5 years or 3 years compared to if they've just started or done it a year or two. And then, you know, there's certainly difficulty that some folks, both in clinics big and small, in health systems and independent clinics, sometimes struggle engaging folks on the front lines. Folks on the front lines are working so hard and fast that sometimes some of this patient-centered primary care home, medical home work doesn't necessarily reach the ground as much as we all would like it to. There are really common barriers that clinics experience. Really, I cannot get out of a clinic without them talking to me about inadequate financial resources in primary care and how the fee-for-service or visit-based reimbursement really inhibits the full implementation of the medical home concept, the patient-centered primary care home concept. They all express struggles with not enough workforce and turnover and staff limitations in terms of training. Really, at times, low adaptive reserve in clinics, folks feeling alone and overwhelmed and fatigued with all of the changes that are occurring in healthcare generally. And then there's the electronic health record, which is, of course, built to be a tool to foster improved care, but is really a scaffold of what hopefully will become in the future of really improving and benefiting the ongoing patient care in the clinic and throughout the healthcare system. And then there were really clear characteristics of successful transformation in clinics that were doing well. A lot of it was about their motivation. If they were motivated by their insurance company telling them that they had to do this, or somebody feeling like they were pressured into doing this, then they're not going to get very far. Instead, if they are motivated by in trying to innovate, to provide the best care possible to meet their patient needs that they have learned about or know about, and their community needs, and to improve patients' health, they're going to get a lot further. Folks that participate in collaborative peer learning experiences, things like the Comprehensive Primary Care Initiative, or CPC Plus is the new iteration of that, which is a multi-stakeholder initiative around the country. Oregon is one of the regions participating in that. As part of that, clinics have to participate in collaborative peer learning experiences where they learn from each other. Folks who receive practice coaching or external support are also further along than others. And then folks who on the ground in the clinic involve multidisciplinary staff in discussions about how to improve patient care, and integrally involve them in both envisioning how care could be better and implementing change in the clinic. Those folks are much further along than folks who sort of have one or two change agents in the clinic. Briefly, this is just a outline of how our site visits are set up. We have 3 site visit folks that visit every clinic, and we designed this structure in order to foster transformation in the clinic. So clinics are selected for a site visit. We have somebody who works with them ahead of the site visit to make sure that the site visit goes well, to talk them down so they're not worried and nervous. And then we have the site visit itself, and we have all of these 3 folks go to that visit and meet with all sorts of different folks at the clinic, including patients. And then after the visit, both the practice coach and a clinical transformation consultant, who is really a peer mentor, a clinician from somewhere in the state who has been doing this work. Those folks who have been to that visit and visited that clinic and talked to folks there can work with the clinic for 6 months afterwards to really work on whatever the clinic wants to improve. So I'm just going to skim through this. This is some of the technical assistance work that or resources that the Health Authority has built up over time. This is something called the Oregon's Patient-Centered Primary Care Institute. There's a ton of resources that have been built for clinics to, again, foster their knowledge and improve the care that they give. This is just a slide. This is me and my team from my clinic. Here, one of the webinars that was put on by the Patient-Centered Primary Care Institute, talking about team-based care. And one of the things that the Institute tries to do, just like the program, is to incorporate real experiences from clinics so that they are really doing the teaching of other folks in the state, and it's not some expert from the state telling them of what they should do better. The Health Authority has also started to host some of these webinar series. Here's a few examples here of some topics: clinical quality improvement, risk stratification, etc., that we've put on recently. And these are really where the site visit staff, the folks that have gone out to visit clinics around the state, talk about areas where they've seen clinics have trouble, talk about their experiences, share best practices, and then incorporate the experience of real clinics to, again, do that teaching of the other folks on the webinar, so that we're really highlighting the best practices of those folks in the state. And with that, I am going to hand things over to Jane Conley, who is representing one of the best clinics in the state, one of our 5-star practices. Jane I've worked with her for a number of years, and I'll just say that one of the things we recognized early on in our transformation process with patient-centered primary care homes is it's important to have an operations leader, a manager, who works with the clinicians and the clinical staff well, and Jane is really a great example of that. And so, Jane, I'll hand it off to you to tell us a little bit about your experience with patient-centered primary care home program over the last few years.
Great. Thank you, Dr. Solino. It's a nice introduction, and I'm happy to speak with everybody today about my favorite subject. My role is really to talk about how we got started. And like probably everybody, we had a sense 5 or 6 years ago that we could do so much better if only, many of the points Dr. Salino brought up, if only we had additional resources, if only we had more money. So here's 5 key points that I want to talk about today. The first one that was really very transformative for us is we decided to hire a second medical assistant for every one of our providers and attempt to convert to a scribing medical assistant model. I calculated that this would pay for itself. I didn't need additional alternative payment models if I could add 1.5 patient visits a day. And so we shot for 2 extra patient visits a day for each provider with 2 medical assistants. This instantly created for us an opportunity for the expansion of the team responsibilities. And such things as depression screening, drug and alcohol screening, fall risk assessments, and chart scrubbing began to be possible. And so our medical assistants today are doing an extremely extensive chart scrubbing prior to every visit, so we can actually be proactive and know what patients need before they walk in the door. It was revolutionary. Over time, it helped us to begin to understand that our responsibilities to our patients went well beyond what happens in the office, and that really an expanded healthcare team is key to that. The second was behavioral health integration. We, like everyone, I would imagine, had a very low success rate in referring patients to community behavioral health sources. Patients just didn't follow up when we gave them a phone number to call and wished them luck. Very low success rate. So we teamed up with a local behavioral health organization who was interested in exploring how to integrate into primary care. We didn't know what we were doing. We just decided to get going. And it started very small, very modestly. We purchased a telephone system with handsets like you'd have in your home and dedicated a telephone line to it. And so when a provider had a patient in their exam room that needed behavioral health counseling, we dialed the phone number, and on the other end there was a designated therapist who was waiting to receive the calls, and she spoke with the patient. We gave the phone to the patient, exited the exam room, and she spoke with the patients and engaged with them and introduced the topic of therapy and set an appointment. And we found that with just that, the engagement of our patients with behavioral health got much improved. But it quickly morphed into realizing that we needed an on-site behaviorist for warm handoffs. And that happened. We didn't know how the billing would work, and we simply gave them a little bit of free space in our office. We charged them no rent, and we started with the warm handoffs. Today, we have in our main office, we have 2 full-time short-term therapists, 2 full-time long-term therapists, a substance abuse counselor, community support specialists, and program coordinators. Last year, we made 2,700 referrals to our behavioral health therapy department, and that comprised 15% of our patients who came into the office. Number 3, make a decision not to wait for payment reform. Begin improving quality and preventive care, and then work with payers to provide incentives. Once they realize that you are really serious about changing the way that you do things, they become very interested in working with you. Realize that there's a changing relationship with payers. Begin to see them as team members who are engaged in the goal of providing better care to the patients just as you are. 4, and this was big for us because we're in an independent practice, look for grant opportunities. We were able to open a second office with financial assistance from our local CCO, our local ACO, to take on a large population of Medicaid patients. And this really helped us in a short period of time expand our role in the community and also create a new model for the way that we saw patients. Partner with larger organizations such as medical schools and say yes to research studies, because this provides access to consultants and data capturing resources that you might not have access to otherwise. Challenge yourself, and that's hard when it feels like the days that we put in are challenging enough. And lastly, and this is an important point, one that we discovered to our happy surprise, the innovation that we are engaged in has made us a very attractive choice for new providers. And so in our community, while many others struggle with hiring new physicians and non-physician providers, we've been very, very successful. We have, in the last 4 years, added 10 new primary care providers to our group, and 5 of those physicians and 5 of them non-physician providers. The young physicians are looking for opportunities that have team-based care and embedded behavioral health, and they are excited about joining with that. So I would encourage you to remember that for those of you who are looking to replace or grow. That's all I have.
Thank you, Jane. That was great. That was great. And I'm sure, you know, at the end here, we'll have folks asking questions. And so folks on the call today, be thinking of questions that you'd like to ask Jane from, you know, to get her frontline perspective, having done this work for a number of years. You know, again, it's seeing practices like Springfield Family Physicians grow through their work in this model of care has been really wonderful. Again, you know, they have excellent leadership, and they're a practice who has been looking for ways to improve, and they found their success that way. You know, there's a lot of question out there. You know, are there, you know, there are many other types of practices out there who aren't as functional as Springfield Family Physicians, perhaps, who aren't as advanced, who may be struggling more, and it's really important to when evaluating success about, you know, a strategy or a policy, especially a state-based or large policy like a patient-centered primary care homes, to think about the big picture and the effect of the overall care that is being given. I think the work that's being done on the ground, when I go and visit practices like Springfield Family Physicians and talk with folks like Jane and many of the other practices, they can show me the areas and are really proud of the areas that they've been working on to improve. And they have data to show and all of that. They're really motivated. But one of the things that has been really foundational to understanding whether this patient-centered primary care home policy works across Oregon in general was the folks that initially built the program thought to evaluate this type of work across the whole population of the state. And so what they did was they looked at the care for 600,000 Oregonians who received their care in a patient-centered primary care home, and compared that to 600,000 Oregonians who did not receive their care in a patient-centered primary care home. And they looked at their care between 2012 and 2014, the first 3 years of the implementation of this model of care in Oregon. There were 2 arms to this evaluation. The slide I'm presenting here is the quantitative arm of the evaluation. There's a whole qualitative arm. There's a link there. You can go and read it. That was essentially looking at 20 high-performing practices across the state and learning from their experience. That is a really great body of work that is very interesting, and I recommend folks take a look at. But today we're going to talk about the quantitative evaluation. And the data really was quite astonishing, looking at this all-payer analysis of 1.2 million Oregonians and looking at the difference in their care over 3 years. What was found in this analysis evaluation was that for every $1 increase in primary care spending, there was a $13 return on investment over that 3-year period. The implementation of the patient-centered primary care home and really the work being done on the ground by folks in clinics like Springfield Family Medicine has resulted in an estimated $240 million in savings to that Oregon's health system during that time period. And clinics actually matured in the model of care. So clinics that had been doing this work 1 year had a cost savings of about $14 per member per month. But by their 3rd year of doing this work, they were saving double that amount. And that makes sense if you think about integrating a care manager or a behavioral health specialist. In that 1st year, you're just trying to figure out who that person is and how you use them. By the 3rd year, you're trying to figure out how to get 2 or 3 more of them because you recognize how valuable they are. that maturation was really demonstrated in the details of the data, showing that upfront or upstream investment in primary care resulted in downstream reductions in utilization of specialty, emergency room, and inpatient care, and those costs again improved over time. And then finally, another key part of the data was really finding that the whole of the model of patient-centered primary care home and medical home model is greater than the sum of any of its parts. So it wasn't good enough to have great access, or to have wonderful continuity, or to have a great quality improvement structure. That didn't have an independent effect on the cost and utilization numbers. It was the model as a whole, those 6 core attributes, those fundamental building blocks of advanced primary care that really made the summative difference in the numbers. So that was wonderful to see that whole process over a period of 5 years, going from, the idea of patient-centered primary care homes and getting everybody at 75% of Oregonians to get their care through those types of clinics and everybody under the Oregon Health Authority, and to have the evidence that this work actually does work. It results in better patient care, lower costs. And so we could have, ridden off into the sunset. Here's the picture from a rodeo, Chief Joseph Day's rodeo out in Wallowa County, our northeastmost county, where our very first 5-star clinic is located. We could, hang back with our friends right off into the sunset here over the beautiful Wallowa Mountains and say we're done. We have everything we needed, except that there was that third goal that the Oregon Health Policy Board gave us back in 2010, that idea of spreading the model of patient-centered primary care homes and the payment for that model to payers outside of the Oregon Health Authority. That was still left undone in 2015. And so the Oregon Health Policy Board and the state, with collaborating with primary care organizations, looked around the country and looked actually to Rhode Island, who back in 2008 had started measuring primary care spending and set a goal to double primary care spending over 5 years. They met those goals and actually had a reduction in total medical expenditures in Rhode Island of $170 million during that time. And so Oregon looked at that model and said, that is a model that we can support. Evidence behind investment in primary care and focus on primary care is outstanding. And we have this wonderful building block of an engaged primary care system. And so let's start moving forward on trying to understand what the investment is in primary care and try and improve some of those barriers, or address some of those barriers like the fee-for-service billing system, like investment in inadequate investment in primary care, that are really fundamental to continued transformation. So in 2015, there was a piece of legislation passed that did 2 things. The first thing it did was require essentially all prominent carriers, all payers in Oregon, just about, to report annually on how much they're spending on primary care, both in terms of claims or fee-for-service and also non-claims-based investments. And then it set up something called a Primary Care Payment Reform Collaborative, a multidisciplinary group of, I think there's about 20 or 30 different types of folks there, probably 50 different members on that group, who was essentially tasked with trying to advise the health authority and the legislature about how to move payment reform in primary care forward. There was a group of really astonishing, I think, and at that time, consensus recommendations that this group of 50 different people came together and endorsed and put forward and presented to the Oregon Health Policy Board. And that set of recommendations went forward through the legislature and became Senate Bill 934, which has a couple of parts that are really important. The first part, which is something that a lot of people are very interested in, was that it set a minimum threshold for all payers, that's commercial carriers of any decent size, our Medicaid ACOs, or whatever we call CCOs, and then our public employees and our teachers, all of those different payers to spend a minimum of 12% of their total medical expenditures on primary care. It's interesting that very few people know how much is spent on primary care when you talk to them. When you do look at the evidence in literature, the average is somewhere around the country, it's somewhere in the 5 to 7% range. And in Oregon, once we had collected the data from different payers, was sitting in our commercial world, commercial marketplace, was sitting in that 5 to 7% range. And so setting a minimum threshold of 12% was effectively, for many of the carriers, doubling primary care spending in the commercial marketplace. For those folks, those payers who were not meeting the target, they essentially had an improvement plan of increasing primary care spend by 1% per year to reach that minimum threshold. This is a similar policy to the one that Rhode Island undertook, allowing room for improvement, essentially, and not trying to be punitive through this process. Another important part of Senate Bill 934 was requiring payers that participated in this multi-payer national state commercial payment initiative called Comprehensive Primary Care Plus to offer those similar payment methodologies that are utilized in that initiative to all of Oregon's patient-centered primary care homes, and then really to continue that collaborative work, that primary care payment reform collaborative work to essentially continue to advise and assist the implementation of the next 5 to 10 years of transformation in Oregon while these payment changes in primary care are taking place. Important tasks or goals that the collaborative was tasked with in shaping this primary care payment reform initiative. The initiative, even though there was going to be a significant increase in primary care investments, that should not result in a increase in cost to consumers or increasing the total cost of healthcare. There would be an effort to improve reimbursement methods, including by investing in social determinants of health. And there would be an effort to align primary care reimbursement by purchases of care so that on the clinic level, that the clinic could be paid essentially to take care of their entire population with an aligned methodology. The efforts would be that the collaborative would include the use of value-based payments, so not fee-for-service, getting away from that office visit-based payment structure, providing technical assistance to both clinics and payers in learning how to work together collaboratively to essentially have this investment be more effective and efficient. To aggregate data across payers, not have everybody looking at their own sets of data, but actually look at the population health and the population of Oregon. To minimize and align metrics, many folks are well aware that there's so many metrics, quality metrics out there. It leads to a lot of overwhelm to essentially focus that work down on the things that everybody agrees are important for primary care transformation. And then the last key point, facilitating the integration of primary care behavioral health with physical health, which we recognize is so very valuable and one of the most exciting parts of transformation over the last 5 years in Oregon. So with that, I'll end on this slide. This is a picture out in Wheeler County. This is John Day fossil beds, the painted hills out there. It's beautiful. And I use this slide. My daughter, here's a picture of me with my daughters a few years ago. And I use this slide because of my daughter's t-shirt, which says, "Today is going to be awesome." And I think that really encapsulates our view here right now in Oregon. You know, there's a lot of change. There's a lot of reasons why we couldn't be successful in doing this work. But we have the engagement of the primary care system. We have a collaborative group of folks who are still sitting down, meeting, coming to meetings, talking to each other, and having enlightening conversations to try and make healthcare and primary care work better. And we have the support of the legislature, which passed that last piece of legislation, Senate Bill 934, unanimously. That means every Democrat and every Republican in the legislature supported it. And so really at a time when there's so much dysfunction at the federal level, and many states there's a lot of political infighting, to have that support at all of those different levels, we're really primed for the next 5 years. And I hope that 5 years from now we can come back and tell you all of the wonderful things that we've continued to do here in Oregon. So thank you very much.
Well, thank you so much, Evan and Jane, for your presentation. It was very, very inspiring to hear all that you've accomplished over a short period of time, from rolling out the patient-centered medical home both to public employees and those overseen by the state, and then in the commercial market to really implementing this, or moving forward on this legislation, where you'll get more resources to primary care. And I think by focusing on putting some of those additional resources into alternative payment models, begin to address some of the barriers on your slide, which relate to fee-for-service and inadequate resources. So I first want to say we've gotten a number of questions related to availability of the slides, and Evan and Jane have agreed to make those slides available, so you will be able to download them. If you have any trouble, they'll be on our website. They'll reside on our website, and you can also reach out to Allison Gross, who's included her email here, if you have any additional trouble. We've got some other questions. We'll kick it off, but please keep your questions coming. One of the first was to ask whether or not the health plans that are primary care homes in Oregon are somehow have kind of proxy recognition from NCQA, and I think the question was in the context of MACRA and the recognition for patient-centered medical homes that's in MACRA. So let me ask Evan if he'll answer that question.
Yeah, sure. So the MACRA rule, the MIPS part of MACRA, the quality improvement part, Oregon's patient-centered primary care home is recognized as an acceptable model for MACRA, for that quality improvement part of MIPS. It recognizes state-based models with more than, I think, 500 clinics recognized, and so Oregon fits under that. There are a few clinics outside of Oregon that are recognized, up in Washington, Idaho, that are recognized as Oregon patient-centered primary care homes because they see public employees of Oregon. We do have essentially a recognition for folks who do the NCQA process, to essentially get some credit for doing that work when they apply as an Oregon patient-centered primary care home.
Terrific, thanks. And here's a question for Jane. And thank you, Jane, for your presentation. It was really exciting to hear what you were able to accomplish and how it fueled the growth of the practice. So that's very exciting. What were the most difficult obstacles you faced?
Well, I think I would say probably two would be a cultural shift in attitude for the staff and the providers. Because even though I didn't recognize it in myself until I was part of this transformation, that our attitudes about our patients are really often focused on when they're in front of us, once they come into the office, and we don't think about them after they leave the office. And so part of this journey was realizing that these are our patients 24/7, and we have to embrace and be accountable for what happens to them wherever they are going on their health journey. And it's a really empowering attitude, but it was a real shift. And the second thing was, it was really interesting how much provider resistance we faced. Not just this office, but in our community, everybody I talked to faced a lot of provider resistance. It was relatively rare to have an excited physician like Dr. Salino in a leadership position. We are fortunate that we have one here in our office. But a lot of it is just a change fatigue. And if you're an older physician, you've gone through so many changes over the years, the latest, greatest idea that was going to make everything better, that you're just worn out. And so resistance to change was really probably the biggest obstacle that we faced.
Thank you so much. This is a question for Evan. So we heard from Jane about some of the barriers that the practice needed to overcome to implement the transformation, and really, in a nutshell, cultural, I would say. Evan, can you speak to the work on primary care investment and doubling the primary care spend? What were some of the barriers that you needed to overcome on the policy level to move that initiative forward? Because unlike when Oregon put the primary care home in place, where this was happening around the country, and of course there was a big national effort, and the PCPCC was very much involved in that. So there was this sort of groundswell related to patient-centered medical home. I think this idea of primary care investment is just beginning to take hold. You mentioned Oregon as one state. Other states are talking about it, but you were actually able to implement that. Can you tell us a little bit about how you overcame, what those barriers were and how you overcame them?
Sure. Yeah, there were a number of discussions before we implemented the legislation that were good multi-stakeholder discussions, but didn't really end up leading to action. And I think that certainly the continued engagement of the primary care community, along with the support from the health authority in the policy work, were helpful. There were a lot of barriers. We have a lot of commercial carriers in Oregon. We are not like some states who have 1 or 2 or 3. We have 8 or 10 decent-sized carriers, probably 10 or 15 if you go to some of the smaller carriers. Our coordinated care organizations or Medicaid ACOs, there's 15 of them around the state, and they all work differently. So trying to get 30 different payers or a large number of payers together was really, really difficult. Actually having the timing of the federal government continue the comprehensive primary care plus program, that initiative was actually very helpful in getting people talking about the same sorts of things. So one of the things we found early on was that the payers and the primary care folks were speaking a different language, right? They were saying the same words sometimes, but really speaking a different language. And the work of the comprehensive primary care plus that federal state work, that alignment that really laid things out conceptually, was very helpful for us to get everybody on board with at least having the same sort of conversation. I do think having the experience of Rhode Island, having the data to look back to and see how that worked, even though it's a small state, the size of one of our counties, there was some experience to look back to and a good outcome. And then really that last piece, the data that I showed, the evaluation data, that quantitative data, that is a really robust evaluation, and that data certainly points in a very positive direction that helps a lot in talking with policymakers, specifically legislators, that this was actually a good thing to invest in and may offer a return on investment that'll benefit everybody.
Thank you so much. Yes, having evidence really can be a compelling case for policymakers. There are over 30 questions that we have, and we can't possibly get to them in the 3 minutes that we have remaining. So we'll work with Evan and Jane and try to answer some of your questions and put them on the website. But in the remaining minutes, there's a number of questions, Jane, related to how you really structured your behavioral health program. How did you have to pay for those phone consults? What is the payment mechanism? Do you have people embedded in your office? How do you refer to psychiatrists? Can you just talk a little bit more about your program and how it evolved over time?
Sure. We we have developed an alternative payment methodology with our local CCO. So that's one thing that we have an increased per member per month payment that helps fund behavioral health for our Medicaid population. That's one way we've done it. We also, with our partner, we have one psychologist that we directly employ. All of our other behaviorists are employed by a different organization that has embedded inside our organization, use our same EHR, but it's a little complicated. It's divided into short-term and long-term treatment. For warm handoffs and short-term treatment, we bill for those services under health behaviors, 96150 through 96155. For longer-term therapy, the behavioral health organization bills for that. And we have been able to successfully get enough payment to continue through a combination of the alternate payment methodologies and with the billable services.
Terrific. Well, I think there are additional questions, but we are at the top of the hour. So please join me in thanking Evan and Jane for just a terrific presentation today. You do have all of the materials, and a recording will be made available on the site. And as I said, we'll work with them to answer some more of these questions and put them on our website. Thank you so much, everyone, for joining. It was a terrific program. Have a wonderful afternoon.